Okay, we're officially recording. This is Unit 6, Class 2 Zoom session. I'm going to go ahead and start by sharing my screen. Maybe. Hold on a minute here. You think I'll figure this out by the end of the semester. Just clicked on the wrong box. There we go. Okay, everybody should be able to see my screen now. Just move some things around so we can get going. Okay. All right, and just like we always do, I will stop periodically and check out the chat box just to kind of see where we're at and then go from there. So, all right, so let's go ahead and get started. And let's kind of review the quiz. So there were 2 questions on there related to medications and mechanism of action, okay? The first one was looking for an example of an antiplatelet aggregate. And the correct answer was the clopidogrel, which is Plavix, okay? The other options that were there, I believe, were anticoagulants or perhaps a thrombolytic. The second question asked about the mechanism of action for anticoagulants, okay? Anticoagulants, remember, they alter the clotting cascade. So if you think back to A&P, all the clotting factors that get made with the liver and all these things need to happen. It's very much like a domino effect. For this cascade to happen and the clot forms. Contrary to public belief, they do not thin the blood. Okay, so the correct answer was not thin the blood. Hopefully nobody picked that. Now, that being said, if you're talking to a patient, the lay person knows these things as blood thinners, and it is okay if you use that term if you are talking to a patient. But if you are talking to a faculty member, you're talking to a professional, a colleague, they do not thin the blood. Okay, off the soapbox. All right, the other questions involved matching, and it was for terminology review. So nystagmus refers to like a twitching or a darting motion of the eyes. So that's one of the reasons why when you're assessing the patient, we do those cardinal fields of gaze. And they move their eyes together following your finger, you know, through the different cardinal fields of gaze. And you're looking for the eyes to move in unison, and you're looking to see if there's any twitching, any kind of spasm there. Diplopia simply refers to double vision. That is very common when we talk about multiple sclerosis, which is one of our topics for today. Ataxia refers to difficulty walking, difficulty coordinating the movements, in particular to walk. Flaccidity refers to the status of a muscle, so it's completely limp, it's completely flaccid. So that kind of refers to your hemiplegia when you're talking a complete paralysis that we're not able to move that muscle. Dysarthria refers to difficulty speaking, difficulty articulating words. And this can be in relation to speech when they're trying to, you know, speak the words and it comes out very garbled, muffled, not making sense. Agnosia refers to the inability to recognize a common familiar object. So if, for example, if you showed a patient a key or they put the key in their hand, they would not be able to identify that. Micrographia refers to very small, illegible handwriting. We'll talk about this in relation to Parkinson's disease today. And then, of course, bradykinesia, which refers to very slow, both movements, physical movements with ambulation, but also that slow speech that you see with your Parkinson's disease patients. Okay, so that was today's review. Just kind of going over that, make sure you know those terms. Because again, I'm not going to ask you the definition of a term on an exam, but those terms might be used in exam questions. So if you're not quite sure what they mean, that could be a problem. Okay. Alrighty. So moving on, if you want to pull out your pre-class prep, you had a worksheet that looked at 4 different neurological disorders. And we're going to talk about these separately, just to kind of look at the differences. But when we start talking about care of the patient, okay, very similar to Unit 5, minus the part where you're treating the actual cause of the problem, that underlying cause, the disease process, your supportive care, your ongoing care for these is going to be very similar. It's also going to be very similar to the rehabilitation phase for a stroke patient. So we're going to kind of pick that up as well. Okay, because when we talk about the different body systems, and we're going to go into detail with that today, but when we talk about those different body systems, it's all about maximizing function and minimizing complications. Okay, so you're going to see as we look at these different disorders today, and you consider the stroke that we talked about last time, from a rehabilitation standpoint, everything's really similar. Okay, so that kind of links back to Unit 5 where we saw that with the different respiratory disorders. So let's just do a brief overview of multiple sclerosis. If you've watched the pre-class capture, if you've looked at the reading, you hit the key points of it. MS is a progressive autoimmune disorder. So autoimmune refers to the body attacking itself. Okay, the immune system is haywire. It's just more powerful than it needs to be, but instead of it attacking foreign substances, it starts attacking self. It starts attacking your body's own substances. So for MS, it's specifically attacking the myelin sheath that are on the nerves of the body. And getting back to basic A&P, you need the myelin sheath in order to conduct nerve impulses. Okay, so that's really what the problem is. So this autoimmune process is happening, and it's destroying the myelin sheath. So as that sheath becomes more and more damaged, and you start getting holes, you start getting areas of the sheath that don't have, areas of the nerve that no longer have sheath around it, that's what affects the nerve conduction. So with MS, there are different types. You know, there's relapsing, remitting, progressive. I'm not really so much worried that you know about that. I want you to really kind of look at MS in general. And one of the things that's very characteristic of MS is it takes several years for it to be diagnosed, because it's just like any other chronic disease where you'll have a flare-up of symptoms and then it'll go away and you'll be all right. And then you'll have a flare-up and then it goes away. And if you look back on someone once they're diagnosed and they actually sit there and take a very detailed history and track their symptoms back, many times they've been having symptoms for several years before that diagnosis. And the classic first sign that we typically see when we do that tracking back is a visual disturbance. A lot of times it's just diplopia, that double vision. It might be blurred vision. Nystagmus kind of accompanies that sometimes, but most of the time it's the diplopia, it's the double vision. Now, rhetorical question, but just think to yourselves, how many times have you been tired, exhausted, you've looked at this computer screen for too long, or you've been reading in your med-surg book for too long, and you're tired and everything starts to look blurry because you're exhausted? It's because of that fact that these minute visual disturbances aren't necessarily followed up on. They notice it, they go to bed, maybe a day or so later, it's gone. Oh, well, I must have just been exhausted. I'm just tired and, you know, I got a lot going on. And they don't necessarily follow up on it because it resolves itself until it happens again. But then it resolves itself and then it happens again. And that's why you have these flare-ups of the symptoms. And until it really becomes a problem or it's becoming very frequent, they might not seek medical diagnosis. So that's why you see that delay in diagnosis. I did want to point out Uthoff signs. So this is just we notice with the symptoms, it's a temporary worsening of symptoms after a patient exerts themselves or they get exposed to heat. So that's pretty classic for MS. You know, that's pretty classic for MS. So we don't deliberately expose them to heat, but that's something that can kind of help hone in on that diagnosis. I did see the question up in the chat box. I'll answer that in just a little bit, because one of the interventions that ATI talks about is potentially using heat, but it's very much a localized heat. If you're having an issue with a muscle, muscle weakness, muscle pain, muscle spasm. When we talk about exposure to heat, we're talking about overall exposure to heat. So when you look at MS, it's very difficult for these patients to live in areas of the country that get really, really warm and really humid. They just don't do well in those areas because that can be enough to kind of set off a flare up of their symptoms. Okay. Other things that set off exacerbations, infection. Infection is probably the most number one cause of that. So when we talk about ongoing management, just like with any chronic disease where you have periods of stability and then you have periods of flare up, you always want to teach your patients to identify risk factors or triggers for themselves specifically. I can look at a list of general triggers, but your patient needs to be taught to identify those triggers as well, things that are specific to them. And really, part of the management is trying to either avoid those triggers or at least minimize exposure to them. But the big one is infection. They might contract an infection, maybe it's a cold, maybe it's a UTI, something that wouldn't be such a big deal to you and I, could be something that sets off some pretty serious increase in symptoms of their MS. So just like with any other chronic disease, okay, you have maintenance therapy, you have medications that they are going to be on all the time, basically to essentially keep the disease under control, to slow the progression of the disease. And then you're going to have medications that you use specifically during periods of exacerbation. So if you think about MS, this is all has to do with an autoimmune disorder. So you have the immune system that's destroying the myelin sheath. So we're going to use medications. We're going to use things like immunomodulators. We're going to use things like interferon to basically tamp down on that immune system. Okay, it's like, hey, you're working just a little too good and you're attacking us. You need to chill out a little bit. So that's something that they're going to be on consistently. That's going to be a long-term thing. The other thing with MS, because it is progressive and when they have flare-ups, sometimes they don't ever completely get back to baseline. The other thing we look at is symptom management. And this is really when we get into the different body systems and we talk about the effect of MS on the GI system and the GU system. Part of that management will involve medications. So you have the maintenance therapy where we're controlling the underlying cause of the problem, and then we have the symptom management. So we're trying to suppress that immune system a little bit so it's not going haywire. When we have an exacerbation, okay, now we need to pull out the big guns. So just like we would do with a COPD exacerbation flare-up, now we're going to start using the IV, the PO, the corticosteroids. Okay, they're generally not on corticosteroids long term. If they are, it's a very low dose. I'm talking like 5 milligrams of prednisone a day. When we talk exacerbation, now we're talking like IV methylprednisone, or you're talking like 40 to 60 milligrams of prednisone. Okay, so that's generally very short term. We want to get them over the hump of that exacerbation. Okay, so that's the main crux of MS in relation to this. Now we will talk about, management for each of the body systems as we go on in this Zoom class, but I just wanted to hit the main points that were part of your pre-class prep. Now on the flip side, if you look at myasthenia gravis, there's a lot of things that it has in common with MS, but there are also some key differences. So myasthenia gravis is also an autoimmune disorder. Okay, so once again, we have our body's own immune system just going way overboard, and it's now starting to attack us. Okay, but for myasthenia gravis, instead of attacking the myelin sheath like MS does, with myasthenia gravis, this disorder actually causes the production of antibodies. And what happens with these antibodies, they actually attach to nerve receptors. And by attaching to them, it blocks acetylcholine. And acetylcholine is one of the neurotransmitters we need in the body to help with muscle movement and just function that way. Okay, so when we talk about myasthenia gravis, you'll see diplopia there again, because again, this is going to, the lack of acetylcholine is going to cause muscle weakness. Okay, so when we think about diplopia, why do you have double vision? It's because you have the weakness in the eye muscles that it's not able to pull things into focus. You also see the development of what we call ptosis, or like a droopy eyelid, okay, with this. That's very, very common with this, with myasthenia gravis. Also facial drooping. Okay, now stop here and think a minute. We talked about facial drooping before, okay, in relation to stroke. So it's very important, if you're noting facial drooping, we want to make sure, go through and do a full neuro assessment. Are we talking about myasthenia gravis? Is this undiagnosed myasthenia gravis, or are we talking about a stroke? Statistically, if you're looking between the two, stroke happens way more often. And if I look between the two, the stroke can potentially kill your patient first acutely. So you would always want to pursue that and make sure that that's not what we're dealing with. Because of this progressive muscle weakness, we get concerned about the patient's swallow reflex. Okay, that's a big concern, aspiration, and getting things down into the airway, into the lungs that don't belong there. And then ultimately, we're concerned about the diaphragm. I mean, that is your body's muscle that's responsible for breathing, okay, for ventilation. So those are all real big concerns. With myasthenia gravis, the symptoms, this is something they're going to experience on an everyday basis, but the symptoms will get progressively worse throughout the day with repeated activity. So with these patients, if they have a rest period, they'll start regaining some of that strength, but as soon as they start exerting it, they're going to get weak again. That's going to be a key cornerstone for how to manage these patients, just simply because we have to make sure they have frequent rest periods. And we'll talk about that, particularly in relation to nutrition, eating, and even conversation. Okay. Now, again, medication management. Okay, we have a couple things going on here. It's an autoimmune disorder, so we're going to use immunomodulators. We might use PO corticosteroids, that very low dose that I was talking about before, the 5 milligrams to 10 milligrams of prednisone. Okay, this is all about keeping the immune system in check. These patients will also be treated with a cholinesterase inhibitor, and we're going to talk more about those in just a couple minutes here. But they are going to be on a cholinesterase inhibitor several times a day. This is going to be very important for them to maintain functioning, and I'm talking basic function, being able to eat, being able to swallow without, choking, keep breathing, that sort of thing. All right, so that maintenance therapy is going to be every single day for the rest of their lives. This is a chronic disorder, just like everything else we've been talking about. When they have a flare-up, we then need to get into exacerbation management. So now they need higher doses of the cholinesterase inhibitors. They may need things like plasmapheresis to try to get those antibodies out of their system much more quickly and get them back to their baseline. Okay, but again, when you look at the things that both MS and MG have in common, they are chronic neurological disorders. They are both autoimmune, and they are both going to affect muscle function, muscle weakness. Okay, so let's kind of take a step back here, and I just want to go over immunomodulators, just the basics, okay? And I will post this PowerPoint and the last class's PowerPoint on Plato. I missed doing that the other day, so I'll put them both up today. So immunomodulators do just what I said they do. We're looking at suppressing the immune system. Now, it's a very fine balance, okay? Right now, I have the immune system that's working haywire. It's going way farther than it needs to go. But on the flip side, if I suppress it so much and I don't have any immune system, then any basic infection, common cold, can become life-threatening. So it is very much a balance. I want to kind of chill the immune system a little bit, that it's not going out of control, but I don't want to suppress it to the point that I'm setting my patient up for infection and death. Okay, so in thinking how this works, we get concerned about side effects, specifically agranulocytosis, which basically means just destruction of blood cells. And I have the term pancytopenia up there. Okay, penia means little or reduction of. So you guys have probably been familiar with, hearing about thrombocytopenia, low platelets, or anemia, low red blood cells, hemoglobin, hematocrit, leukopenia, low white blood cells. Pancytopenia just refers to a reduction in all of those blood cell types. Okay, so we see the pancytopenia here, but we're most concerned with the neutropenia or the leukopenia, with the reduction in the white blood cells. And again, it's all about getting that balance that I talked about before. Okay, we want to suppress it enough that it's not going haywire, attacking itself, but we don't want to knock them down too low. So it's very important that these patients that are taking immunomodulators, whether it's for MS, myasthenia gravis, lupus, any other autoimmune disorder, ulcerative colitis, Crohn's disease, anything like that, when they are on an immunomodulator, it is going to affect their ability to fight infection. They are going to be at higher risk for contracting an infection. So it's very important that they pay attention and perform those standard infection prevention measures, the good hand hygiene, the keeping the hands away from the face, making sure that you're avoiding sick people as much as possible. Also nurturing, just your regular overall health. Okay, their diet's going to be important. Staying hydrated is going to be important. Getting enough sleep and rest is going to be important. Now, in general, with your immunomodulators, they can cause some nausea. So typically we're going to give it with food. Now, just to minimize the side effect. It doesn't really make it work any better. It doesn't make it work any worse. It is very important, though, because of how these medications are processed in the body, that these patients need to stay hydrated. This can actually cause some kidney issues if we're not careful. Because of the decrease in the white count, the decrease in the immune system, they will have periodic CBC draws just to kind of see how they're doing. And again, we want to suppress the immune system a little bit. We don't want to suppress it too much. Now, I want to go back to the previous slide because I forgot to mention something here. Back under MS, where it talks about interferon underneath the immunomodulator, it's similar to the immunomodulator, but it's kind of its own little subclass. Interferons are very specific because they're trying to target certain areas of the immune system and kind of get it to help itself. So I have in parentheses there the reaction protocol. What that basically means is your interferons, when we give them to patients, they tend to be very effective. And we're going to talk about interferons in relation to cancer treatment. So they do tend to be very effective, but when we give them, when we administer them, they often cause this like flu-like syndrome in your patient. So they'll typically run a temperature, they won't feel well, they'll have the myalgias, your typical flu feeling. So knowing that, we will pre-medicate them either with acetaminophen or ibuprofen, and we will have them continue that usually for at least 24 to 48 hours afterwards. But we'll talk a little bit more about that in relation to when it's being used for cancer treatment as part of the oncology management. But they kind of go along with the immunomodulators, which is why I wanted to, make reference to that now. I want to bring up a particular medication. It's an antispasmodic baclofen. This is something that's very commonly used for your MS patients, particularly related to not so much the muscle weakness, but your MS patients can develop this muscle spasticity. So baclofen is used pretty frequently for that. There's other different types of antispasmodics out there. We sometimes use these to reduce the spasms in the urinary bladder. Baclofen's not used for that, but there's other types that are. But basically, this is all about enhancing GABA, and it produces the sedative effects when we're trying to chill out the muscles. Biggest issue with these are the CNS depression. It will make your patients sleepy. So obviously, you want to know how the patient's going to respond to that. Don't obviously want to be driving until we figure that out, certainly not operating heavy machinery or making really important decisions. And, this is a symptomatic medication. When we talk about symptom management, if the MS patient is experiencing the muscle spasms and, it's really getting to be an issue with their ADLs, we have to balance using this medication along with the side effects. So if it completely sedates them and snows them that they're just not even functioning, we can work around the doses a little bit and try to balance something that works. But that CNS depression is a real concern, particularly if they are taking it with other medications that may cause CNS depression, or if they are combining this medication with alcohol, definitely going to suppress things. Other side effects were nausea, so you're going to administer it with food. Because it is an antispasmodic, this can cause urinary retention, because if you think about the basic process of urination, your urinary bladder is a muscle. It does need to contract in order to release urine to the outside of your body. So patients who are on this are going to be at higher risk for urinary retention. Somebody that already has urinary retention, for example, a gentleman with BPH, you really want to be very careful with this, because that might make that a little bit worse. This will also result in constipation, okay? Because again, we're kind of chilling out the muscles, we're slowing everything down. Well, you have smooth muscle in your GI tract that has peristalsis. So if I'm slowing everything down, that's going to result in constipation. So it's really important that we use those non-pharmacological measures first, increasing the fluid intake, increasing the fiber intake. Again, if you're going to use a laxative, your bulk forming laxative that provides the additional fiber is your safest. It's really not a good idea to use your other ones, your stimulant laxatives, stuff like that, because you can become dependent on them. Baclofen also has a side effect of potentially causing seizures. So of course you would want to, monitor your patient for seizure activity. You see this more with new dosing or changes in the dose strength, okay? So that's, if it's going to happen, that's when it's most likely to happen. So certainly you want to teach your patient about that. These medications, because it does affect the nervous system, if we very quickly withdraw them, you can see a withdrawal reaction. So, and again, you have that increased risk for seizures with the baclofen. So we want to be really careful with that. All right. So the other medication that I wanted to talk about was your neostigmine or your mestinon, and this is specific for myasthenia gravis. Okay, so the things that we're talking about before, you saw more with MS. This one is specific for myasthenia gravis. So this medication is going to inhibit that breakdown of the acetylcholine. So basically there's more acetylcholine present at the neuromuscular junction, and I need the acetylcholine in order to have, the neurotransmitter to cause muscles to contract. Okay, so I have the building blocks to make my muscles contract and perform my ADLs. So with this, there are some side effects. It can cause some diarrhea. It can cause abdominal cramping. So those are probably the most common. With the neostigmine in particular, which is a slightly different form, you can see an increase in secretions, okay? Which this kind of ties into the diarrhea piece, but you can see excessive saliva production or respiratory secretions. That can become a problem if your patient is not able to clear their own airway. So it's very important when we think about our myasthenia gravis patients, we worry about airway and we worry about ventilation. Those are our two top priorities with this medication. Okay, now with the mestinon in particular, this one has a very short half-life. It has a quick onset of action, a very short half-life. So this is given daily, but it's given in divided doses, and we do it about 4 times a day. It is very important that the doses are administered on time, because they are timed specifically so they are peaking at your standard meal and snack times. Because when you think about it, what is the time of day that if they were to experience muscle weakness, that could be the most potentially damaging to them? And that's generally when they're eating, because we worry about the swallow, their swallowing ability with the strength of the swallow muscles. And then of course we worry about their ventilation muscles. So it's very important that these are timed appropriately in relation to their meals and their snacks. And, you know, in general, if you're working on a general medical floor or telemetry floor, usually patients that we take care of with myasthenia gravis, that's not the main thing that has brought them into the hospital. Maybe they're there with an infection, maybe they're there having surgery, they're there with something else, and the myasthenia gravis is part of their past medical history, but it certainly impacts the care that we are providing. I personally have had very limited interaction with patients with actually myasthenia gravis, but one of the most memorable was when I was a new clinical instructor and I had a bunch of fundamental students. So, you know, in fundies at first we're, you know, learning to talk to the patient and do all that. And, you know, it was really neat. I forget what the patient was actually in for, but she had a history of the myasthenia gravis, and you know, the student was in there and talking to her, and, you know, they were having a pretty good conversation, although, you know, the patient did more, you know, yes, no answers, you know, just kind of shaking her head or nodding. And, you know, I remember her reaching out her hand and touching the student's hand and says, okay, I need to stop talking now. I need to rest before lunch. And that was part of her disease management, knowing that she could not tax herself by having a huge in-depth conversation because it would affect her ability to eat, even with her medication. So again, we don't necessarily see these patients a lot in the hospital for myasthenia gravis, unless we're talking the ICU setting where they're actually now in a crisis situation, which we're going to talk about in just a little bit. But again, it's a chronic neuro condition. So when we think about managing, we're treating the disease process, but everything we're doing is really looking at maintaining function and trying to prevent or minimize complications. Okay, so let's kind of take a moment before I go into the NCLEX question. Let me pull out the chat here quick, and I'm going to go through and just answer anything kind of related to MS or myasthenia gravis. So if you have questions on those, throw them into the chat box really quick. Let's see here. Let me go down here. Okay, how often is plasmapheresis done in a patient with myasthenia gravis? So plasmapheresis is not a first-line treatment. This would be used for a patient that's having repeated episodes, flare-ups, and for one who the standard medication therapy does not work. So we can do plasmapheresis, which is very much like blood donation. So they will insert 2 needles. They're taking the blood out of the one needle. It gets circulated through this plasmapheresis machine and then returned back to the patient. So the plasmapheresis actually removes these antibodies. Okay. So they remove those antibodies, and that's when we're trying to get rid of those, because it's the antibodies that's actually causing the blocking at that neuromuscular junction. So the other treatment they can use for patients that don't respond to, you know, your traditional myasthenia gravis protocol is to potentially do a thymectomy. Okay, the thymus gland, not the thyroid gland. Okay, the thymus gland, which sits underneath your breastbone in the thoracic cavity. As we age, that thymus gland actually begins to shrivel up and deteriorate, and it doesn't do as much as it did when we were kids. In patients with myasthenia gravis, their thymus gland never kind of shrivels up. It's still there. It's still working fully as an adult, which is causing some of the myasthenia gravis problems. So for them, thymectomy may be an option. Okay. So does myasthenia gravis have effects on cardiac muscle as well? It can have some effect, but the biggest thing that we worry about is the aspiration, and really it's about ventilatory failure, looking at the diaphragm. All right, PrepU stated that an intervention with MS is heat therapy during spasms. Yeah, so I addressed this a little bit before. So that heat therapy is very localized, and we're using it to try to loosen up that muscle. So that small amount of heat therapy should not stimulate a flare-up. We're looking at symptom management. The Udhoff sign in response to the heat, that's more like a generalized heat. You would never have this patient, you know, taking a hot shower, a hot bath. While it sounds really, really good to us, not such a good idea for your for your MS patient, okay? Being out in the humid air and the hot humid air, not a really good thing for your MS patient, okay? Do we need to know the 4 kinds of MS? I would not focus on the different kinds of MS. I want you to know MS just as a general overall concept. Understand the basic disease process and the medication management. But most of what we're going to focus on as we go further on in this class with the other disorders as well is going to be about long-term. You know, what are we doing to maximize functioning? What are we doing to prevent or minimize complications? Question at the top. Okay, the COMT inhibitors and all that in Parkinson's, I'll get to that once we get to Parkinson's, okay? So let me minimize that. Let's take a look at the NCLEX items. So now, in reviewing MS and looking at what you had for prep and the ATI, so now you're the RN, you're providing discharge instructions to a patient who reports diplopia and muscle weakness. So which information should be included in the teaching? Okay, so let's kind of work this through. You can go ahead and put what you think your responses are in the chat box and we'll kind of see how that works out. Let's look at number 1. Okay, oh, I see a lot of D's here. Okay, very good. Okay, so keeping a patch over the right eye at all times. You know, when we talk about the diplopia, you think about why is this happening? And it goes back to the pathophys, the damage of the myelin sheath. So when you think about double vision or lazy eye that you often see in kids, where they might patch their strong eye to kind of strengthen their, you know, weaker eye, that's not the underlying cause of the problem here. So the patch is not going to make a difference in their symptoms. So I'm going to eliminate A. Plan to reduce stress by taking a hot bath each day. Well, that kind of sounds good to me, but I don't have MS. So yeah, definitely not our MS patient because that could actually increase their symptoms and stimulate a flare-up. So I'm going to eliminate B. Enroll in a moderate high intensity aerobics class to promote heart health. Well, if I wasn't talking about an MS patient, would that help heart health? Sure. But is that appropriate for my MS patient? No, that's way too much. D, plan periods of rest throughout the day. All right, so we're thinking D. Most people pick D and the correct answer was D. Okay, so things that are important with your MS patient, just like your myasthenia gravis, you want to have rest periods throughout the day, but you also want to maintain muscle strength and coordination. The eye patches I mentioned before, we used to use them more with MS and we don't really anymore. If they are still using them, they have to be alternated. But again, that's not something typically we're using a lot as much anymore. As I mentioned, soaking in the hot tub, vigorous exercises, we're going to cause that flare up. So that's definitely not something we want to be doing. Okay, so now you are the RN, you're getting ready to administer PO meds to your client with myasthenia gravis. So what is your priority action? Okay, what is your priority action? And you can go ahead and stick your answer in there. See what you think. There we go. Now they're rolling in. I got to figure out how to do this poll. All right, looks like we're pretty much set on C. So yeah, let me ask you a question though. Since we've been going over, you know, test taking tips and that, and we talked specifically about myasthenia gravis, you probably really honed in on C because we're worried about that swallowing piece, okay? But is it important to have the client empty their bladder? Sure, we want to prevent UTI. How about those top side rails? Are they a safety thing? Okay. Repositioning, does that help prevent skin breakdown? Absolutely. Those are all important things and things that we would do, but what specifically applies to myasthenia gravis and what specifically is going to be the priority for that patient when we're giving PO meds? So before I flip to the next slide, I just want to point that out because it helps reinforce the fact of really looking at what the question is asking. Okay, what the question is asking to help you narrow it down. Because side rails could be important when you're looking at it from a safety perspective, okay? So, correct answer was C, so give yourselves a pat on the back. We worry about the weakness of the muscles of the face and throat. And again, that's going to increase their risk for aspiration. So if you go back to your basic prioritizing framework, airway, breathing, circulation. So checking the client's ability to swallow before giving the PO meds. And I want to point out, you know, it's not enough here to just check for a gag reflex, okay? Because that's not what we're talking about here. We're actually talking about the muscle strength of the swallowing muscle, the muscles that participate in swallowing. So just simply having a gag reflex is not enough. So you do want to check their ability to swallow before you give those meds. So a really tiny sip there. But this is also really important in timing those meds. You're not giving a ton of stuff at once. You really need to space things out. And again, as I mentioned before, while using the top side rails might be an important aspect of safety, for this patient, what is the higher risk here? Aspiration or falls? Okay, so it goes back to that basic prioritization framework. Nurse logic. Okay. All right, so with myasthenia gravis, I want to talk a little bit about crisis, okay? And we have myasthenic crisis and we have cholinergic crisis. And when I talk about under medication or over medication, over medication is they literally have had too much medication, or maybe this is the very early parts of we think this is myasthenia gravis and we're doing the tensilon testing to confirm the diagnosis, okay? What you will see though, for the most part, if you get somebody who is in the hospital with an acute flare-up of myasthenia gravis, it is generally because they are in a myasthenic crisis. So what happens here is they're taking their regular dose of medications, okay? But something happens with their body. A lot of times it's because of an infection, but their body needs go up. So the regular dose that they've been taking, which normally covers them, is just not enough right now. This is very similar to the concept of a patient who's on methylprednisolone, an IV steroid. So normally, I'm a diabetic. So normally, my blood sugar medication, I'm good. Okay, I take my meds, I follow my diet, I'm good to go. But if I had a flare-up of something and I required IV Solumedrol, it's going to shoot my sugar up. Okay, my basic regimen is not going to be enough to cover it. And it's the same type of concept with this myasthenic crisis. So when we say it's caused by under medication, yeah, it could be caused by somebody not taking their medication, but more times than not, it's caused by them taking their medication, but at this particular time and what's going on with their body, it's not a high enough dose to cover the body needs. So what happens with this is you'll get the respiratory muscle weakness, okay? The muscles will become progressively weaker. And again, we worry about the diaphragm. We worry about that because of ventilation. So they'll get generalized muscle weakness. We worry about the respiratory muscle weakness. They'll develop incontinence. They'll be fatigued. They actually develop hypertension with this as well. The way you can very quickly identify this is they can do a tensilon test. They'll give a small dose of tensilon and their symptoms will improve. Okay, we know what's going on. Now we're going to go ahead and treat them with the cholinesterase inhibitors. They need a higher dose. Okay. Basically get them up to where they need to be. Now, here's the problem. A lot of times they're in ICU because by the time they get there, we're seeing significant respiratory muscle weakness and now they may require mechanical ventilation. So that's why we're talking ICU level care. Once we start getting the medication and the level under control and kind of get that muscle strength back, they'll do all right. And we're able to wean them off of that, get them reestablished, okay? But that's your bigger thing. This is what you're typically going to see if you have a myasthenia gravis patient in the hospital. On the flip side, what we call cholinergic crisis, this would be if the patient has too much medication. Okay, so maybe they overdose on their medication, or the other time that this happens is you've had a patient with myasthenia gravis who's been doing okay, they're on this medication regimen, but now the doctor has decided that they're a surgical candidate and they do the thymectomy. or we've tried, we did plasmapheresis and we removed some of these antibodies. So now they're getting the same dose of medication, but there's not as many antibodies circulating. So they essentially are going to be overdosed. They have too much of the medication beyond what their body needs. Okay. So what happens with this is the muscles kind of go into hyperdrive. You have this constant muscle twitching. And the problem is the muscle can only do that for so long. So this will affect the respiratory muscles. They will become fatigued because of overstimulation. Okay. The other thing you see with this is an increase in those respiratory secretions. So now not only am I worried about my diaphragm failing, I have increased respiratory secretions that are going to block up my airway. Okay. So even if I'm ventilating them, even, you know, if we're giving them oxygen, I have increased respiratory secretion. So if they can't clear their airway, I'm going to have airway obstruction. Okay. With this, if we give a dose of tensilon, it's going to worsen their symptoms. So essentially, we need to give a reversal agent for tensilon. We need to give a reversal agent for the cholinesterase inhibitors. So we're going to give an anticholinergic, and typically this is going to be atropine that we're going to be giving to reverse this. What I want you to understand here is both of these are going to be life-threatening. And it goes back to the same basic airway, breathing, circulation. But these are crisis situations, and a lot of times they are going to require that mechanical ventilation for us to support the oxygenation that their body needs. Okay, let me check up here in the chat box. Is tensilon toxic? Why is it not used? So tensilon we give, it is parenteral, so that is not really an option for them to be doing at home. The other thing is a little goes a long way, so you can get very, very far and cause some problems here. So when we think about long-term medication and something that they can do at home, we need something that has a very short half-life, that we can control, you know, the onset, the peak, and duration, and really give that at specific intervals of when that would be most beneficial for the patient. Very good question. Okay, all righty. Let's see here. Okay, so we're going to switch over to Parkinson's here. Parkinson's, there is overstimulation. It's the basal ganglia part of the brain. And again, we have our good old friend acetylcholine. Basically, when we talk about a balance, you have acetylcholine neurotransmitter and you have dopamine. There's some other stuff too, but those are the two big ones that we're talking about. So there's too much acetylcholine because there's not enough dopamine. And really what causes the Parkinson's symptoms is this excessive acetylcholine, not enough dopamine. So the lack of the dopamine, it can be because there's just too little production, presence in the body, or it can be because the body is actually destroying it. So either way, when we start looking at medications, we're going to be looking at things to help correct that balance. Okay. So symptom-wise, there's some very classic things of Parkinson's. And if you haven't opened it, if you actually open up the electronic version of your ATI Med Surg book, and you can do that on the ATI website, there's actually a video in there that shows a nurse working with and assessing a Parkinson's patient. And if you haven't experienced interacting with a Parkinson's patient before, the video is definitely a good watch. It's like 4 to 5 minutes, but it truly shows the classic signs and symptoms of Parkinson's. Now, Parkinson's does have stages. There's 5 stages. I'm not really concerned that you understand all the stages. Just understand as we move from 1 through 5, the disease is progressing. Their symptoms are getting worse. By the time you get to the end stage, you also start seeing some cognitive issues, even to the, to the point of some paranoia, which I'll talk about in just a minute. But your typical symptoms that you're going to see, and there's the patient on the screen, it's a very short, shuffling gait, and their posture is tilted forward. So those two things together are going to put them at major risk for falls and injury, because that forward tilt posture changes their center of gravity. So they're very prone to falling forward. That short shuffling gait, makes them more prone to getting caught up on things. So you think about those dreaded throw rugs, or, you know, I think about you go out to a restaurant or someplace and they have those mats. They're kind of like throw rugs, but they're really thin. They're stuck to the floor. But sometimes that's just enough for them to trip over and, you know, cause a fall. In relation to their speech, this kind of goes with that bradykinesia, that short shuffling gait. They will develop a very slow, monotonous speech. And, you know, that monotone that they use, it almost reminds me of that, I forget what that guy's name is. He's a financial analyst. He was in Ferris Bueller. He played the high school teacher, where he would just talks and it's just that same monotonous tone, that, you know, it's just there. Yes, Ben Stein, thank you. But it's that monotonous tone. The other thing that goes along with that is they will develop a very blank facial expression. So when you combine that with the monotonous tone, it really causes some issues with communication. When you think about talking to somebody, you know, right now I can't see any of you. Some of you have your videos off, and obviously I have my PowerPoint up right now, so I don't see anybody's video. But when you talk to someone, even if you can't see them, your tone, your nonverbals, how you say things, you know, just the higher pitches, lower pitches, the speed of your speech really gives a lot to the conversation. And when you have somebody with Parkinson's, they have that monotonous speech, but they also have that blank facial expression. So it makes it very difficult for them to communicate, because you miss those nonverbal cues and even the cues within the speech itself. You know, when I was in high school, I worked at a personal care home as a nurse aide, and then, you know, progressed on to be a med tech there as well. And we had this wonderful, wonderful resident, and I will never forget her. But I participated in her care for probably about 2.5, 3 years, you know, between college, you know, high school and college and everything. And it was interesting to see how her Parkinson's progressed, and, you know, the development of the symptoms, and, you know, her blank facial expression. And you could look at her and she would have the same tone and the same facial expression if she said we were having meatloaf for dinner, as she would say, you know, we went out for a walk today and I saw an animal get run over in the street. There was really no emotion there. There was no change in the speech. And, you know, you could kind of see how she progressed. The tremors that they have, you know, initially you'll notice them most at rest. If the patient's moving, they're not as apparent. As the disease progresses, though, they will progress to just gross tremors all the time. So when we talk about disease management, our goal is to slow the progression. So if you go back to the pathophys, we have that imbalance with the acetylcholine and the dopamine. So we're going to use medication to try to fix that. And it's all really about symptom management and maintaining safety and function, which again, we're going to get much more into that in just a little bit here. But it really, Parkinson's is a very, very rough disease. And I mentioned when it gets to the further stages, stage 4, stage 5, you start seeing some of that cognitive impairment. You can see paranoia. My little lady resident that, you know, I was talking about before, for her, I honestly think that was the most heartbreaking part of her disease, because she was a Holocaust survivor. She, you know, her parents died in a concentration camp. She survived. I don't know how, you know, I never actually got the conversation with her to be able to have that. But when she started experiencing, you know, the dementia, the psychosis, she, in her mind, she saw SS men sitting over on her couch, on her chair, and just the look of terror. And, you know, what was very interesting is because of the blank facial expression, you know, you couldn't see it on the face, but you could see it in her eyes. Just the terror, just the sheer terror that she had was just, you know, it's just horrible. It's just heartbreaking. So, you know, Parkinson's is a really, really difficult disease process to have. So when we look at ongoing care, it's really about maintaining their function, maintaining their safety, supporting the patient, but also supporting the family as well. So let's take a look at some of the medications for Parkinson's. And the gold standard, the first go-to is going to be your levodopa and carbidopa combination. And together it's known as Sinemet. It's a combination drug. So basically what happens is it's a combination drug because the one side turns into dopamine, and the other side helps that dopamine get across the blood-brain barrier into the brain. So they have to be given together to be the most effective. Something you need to understand about this is this is very useful, especially at the beginning of treatment. But after about 2-3 years, the effects that you see of this really drop off. So that's important to tell families, because this is not the miracle cure that they might think it is, especially at the beginning, because when we first start giving this, we see some phenomenal effects. Like the patient really does tend to see an improvement in their symptoms. They're doing better. But there's a timeline for that. There's a time frame for that, and it isn't going to last forever. So that's a very important point to make with both the patient and their family. So side effects of this, particularly as it goes on, as we get farther onto this treatment, you can have the drowsiness, you can develop dyskinesia. So they might have head bobbing or some tics. You'll see the return of tremors. The biggest one initially that you can see is the orthostatic hypotension. So when we start a patient on this medication, it's important that we're watching their blood pressure. Very likely this patient does not just have Parkinson's, they may also have hypertension. So they might be on other medications to treat blood pressure. Those things together with your Sinemet can cause an increase in the orthostatic hypotension. And we already know, based on their posture and their gait, they're already at high risk for falls. So that's a real concern. Psychosis, in some patients, this can actually precipitate a psychosis. So it's something to kind of watch for. Malignant melanoma, I want to mention this. This in and of itself will not cause malignant melanoma, but if your patient already has the precursors or they've had malignant melanoma in the past, this will stimulate a very rapid growth. I don't know why, okay? That's kind of above my pay grade, but that's a big thing that you want to kind of look at. So again, as RNs, we're not prescribing this medication. That is something that the physician should take into account. But as an RN, if I'm talking to the family and all of a sudden we identify a history of melanoma or a family history or something like that, I definitely need to call the provider and let them know about that, because that's a factor that would likely result in the medication regimen being changed. So some things that are really important with the Sinemet, and it's very common that this will be spaced out throughout the day. A lot of times patients will get dosing, 4, maybe even 5 times a day. So you need to kind of think about the timing of this, because if you're taking it at the same time as foods that are high in protein, it actually delays absorption and it can reduce the therapeutic effect. So I don't want to completely cut down their protein, because protein helps provide the building blocks that your body needs. But it's very important that that protein be spaced out throughout the day, several small portions. Vitamin B6 will actually decrease the effect of Sinemet. So again, if you're taking vitamin B6 supplements, you want to make sure those are spaced away as well. MAOIs are a type of psychiatric medication. They are a group of medications, those MAOIs, that interfere with a lot of other different medications as well. So there's a lot of things where they do not support concurrent use. For this particular medication, if they're used together, or I think it's within 2 weeks after the MAOI has been stopped, it can actually put somebody into a hypertensive crisis. So that's a big thing. Again, as nurses, we're not prescribing the medication. That would be a big red flag that the provider should pick up. And certainly the pharmacy computers would pick up if a patient was on these 2 medications at the same time. Tapering doses or drug holidays. I mentioned before that this particular drug becomes ineffective usually after about 3 years. So what we might do, the provider might do to kind of extend that, is they will do some times throughout that 3 years where they kind of take the patient off the medication for a month or 2, just to kind of give them what we call a drug holiday. In some cases, that has extended the life cycle of positive effects of Sinemet. For other patients, it hasn't, but it is still a technique that is used. Okay, so looking at your other medications, your dopamine agonists. So this is your bromocriptine, your pramipexole. These will make the available dopamine more effective. Okay, so a lot of times you will see these used in conjunction with Sinemet. So if I use these, they're gonna make that available dopamine more effective, so I don't need as high of a dose of Sinemet, and that may also prolong the life cycle of the Sinemet as well. The problem with these, it can cause drowsiness, sleepiness, it really just even a sudden inability to stay awake. So that's a big concern, because we want to treat their symptoms and treat the disease to maximize function. And if they're completely snowed all day, that's not what we want either. So again, when you use this with the Sinemet, you can also have that increase in the orthostatic hypotension. I do want to mention, and this is actually in your ATI book as well, this in some people, and honestly, they've done research that it usually happens about 8 to 9, 10 months after they initially start on therapy. These patients can develop an impulse control disorder. And, you know, when they really started using these a lot for Parkinson's, especially in Pennsylvania, once the casinos came and everything, there was a huge uptick in your gambling disorders, that impulsive gambling, impulsive shopping with Amazon, everything else. So this is an issue. You know, the research is kind of out there. I'm not really a psych nurse, but I just found that very interesting to kind of look at that. And, you know, if you think about the progression of Parkinson's too, when you start seeing the cognitive decline, you know, that they're not making very good decisions to begin with. And if you kind of couple that with this impulse control issue, that can cause a problem. So, but again, the whole idea is if we're using this with the Sinemet, we're trying to control their Parkinson's symptoms, always about maximizing function and trying to keep this patient safe. So you can see, you know, changing the position slowly is going to be important for that orthostatic hypotension. Now, this next one is quite interesting too. So amantadine, we've actually used that sometimes to even treat viral infections. It's quite interesting, but this actually releases stored dopamine and it prevents the reuptake. So you're going to get those atropine-like effects. So remember that we talked about anticholinergics and, you know, the mad as a hatter, red as a beet, you know, all of that. So they will get the dry mouth, their pupils will dilate. So if you have somebody who also has glaucoma, this is not an option, because when they dilate the pupils, it'll spike the intraocular pressure. This also will cause urinary retention. So if you have a patient who already has BPH and urinary retention, this is not a good choice. Definitely will cause constipation. So again, just nursing implications for that relate to basic function, increasing the fiber, the fluid, the activity, obviously non-pharmacological things before we get to laxative intervention there. All right, so your COMT inhibitors, these are all about decreasing the breakdown of levodopa. Biggest issue with these And then I'll pull up the chat box because I remember there was a question about this. This one can cause the liver failure and the rhabdomyolysis. So let's start with this for a second. So if we know there's a risk to the liver, it's going to be very important to monitor liver function tests. The other thing that would be important is to really watch medications that we know that tax the liver. So using acetaminophen in these patients would not be appropriate, okay? We also want to make sure that we're promoting hydration. So now this rhabdomyolysis, so what happens with this? And this kind of leads into the liver failure. This all has to do with how your body detoxifies and processes things, particularly when cells rupture, or there's damage to cells, cells die, and how your body processes all of that. So when we talk about rhabdomyolysis, the other types of patients that we see this a lot with is your trauma patients, where, you have skeletal muscle damage, those proteins, those inside of the cellular contents are floating through the bloodstream and getting filtered by the liver. And basically these toxins build up and the liver can't function and actually causes failure of the liver. So when we talk about lab results and we talked about cardiac, and remember we talked about CK, and then we looked at CKMB that was very specific to cardiac. CK looks at muscle damage overall, and you'll see that elevated in rhabdomyolysis. So it can be very, very serious. It can become life-threatening. So, when we look at that, that tends to be an issue. Let me take a look at the chat box. I want to make sure I go back up, make sure I hit that. Okay. Oh, do we need to know the 5 stages of Parkinson's? Not the exact stages, but just kind of know as it progresses through from stage 1 to stage 5, your symptoms are getting much worse. And it's kind of sad to see that too. I had a close friend and mentor who developed Parkinson's disease, and she was actually on my thesis committee when I was working on my master's. And she did everything by hand. So instead of, I typed obviously everything on the computer, but I used to have to print and send her a hard copy. And, if I go back and look at my work and I see her handwritten comments on there, like from the beginning of her diagnosis, towards the end of my project, she is still alive, but towards the end of my project, you could definitely see the change in her handwriting. It was, to be honest with you, it was atrocious. It was very, very difficult to read. All right, so the Compton, and then there's other MAO-B inhibitors. So remember I mentioned before MAO inhibitors. Now these are MAO-B inhibitors, which are a little bit different. So they're not exactly related they don't exactly related to the MAOI inhibitors, are a little bit different. These will decrease the wear-off effect of cinnamon, but they're not used as much. You see it a little bit with the Compton, but there's other ones that are in the same class. They react with tyramine it's a chemical, not really a chemical, it's like a protein chain that's in food, certain types of foods that can cause that effect. So again, we go back to that hypertensive crisis. Don't typically see these a whole lot. And then you have your centrally acting anticholinergics. So benztropine is probably your most common one there. Again, where all of these are going back and looking at trying to adjust that balance of the acetylcholine and the dopamine. So, when you think about this, it was the same thing we talked about with the antihypertensive meds. There's lots of them out there. They all work in slightly different ways, but the goal at the end of the day is the same thing. We're looking at balancing the dopamine and the acetylcholine, and basically to, manage the symptoms. So again, here we have the sedation, we have the drowsiness, you have that same atropine-like side effects. So you'll see the similarities with these. So again, you want to focus on those common threads, across the board here. When you're giving Parkinson medications, it's always making sure, they're having protein, but we generally space it away from the protein. And really, when we talk about Parkinson's, It's going to be about managing the effects on their body, the symptom management. Okay, so let's take a look. I have 2 NCLEX items related to Parkinson's. So when is the best time to assess for tremor in a client with suspected Parkinson's disease? So you can go ahead and put your answers in there, and then I want you to stop and think what this question is asking. Do we know that they have Parkinson's for sure? No, it's suspected. So from that, do you think they're going to be late stage, or do you think they're going to be early stage? Okay, and let that help you answer the question. Okay. Oh, only a few brave souls are putting into the chat box. Okay, I see a lot of A's there. Okay. All right. So A is actually the correct answer. So I'm going to pop back for a second and then we'll come here. Initially, the tremors are going to be very mild, and they're going to notice them. They're going to be noticeable at times of rest, because when they're moving, they're so slight that you're not necessarily seeing them. So anytime they're performing fine motor skill, towards the beginning at least, anytime they're performing fine motor skills, or they're doing something gross motor, so ambulation, eating a meal, occupational therapy, you're probably not going to pick them up. So you're going to notice them initially for very early Parkinson's disease at times of rest. This is why it's very important when you're documenting in your narrative assessment or in your EHR assessment, and you document tremors. Are they happening at rest? Are they happening with movement? Are they very fine tremors? Are they more pronounced? So you want to be very specific in your documentation in describing that, the same way you would describe sputum. Okay. All right. An older adult male is at the primary care provider for an annual visit. Which statement by his wife suggests the client may be experiencing the beginning stages of Parkinson's? Okay, so let's take a look at the options there. What do you know about Parkinson's? Oh, I wish I could do that. Eat all the time to keep losing weight. No, has trouble remembering the names of people we've known for years. Joint stiffness, he moves so slowly. So let's see what we got here. All right, I see a lot of D's. You definitely know your Parkinson's disease. Okay, so before we go to the next slide, okay, he eats all the time but keeps losing weight. Not indicative of Parkinson's disease, but keep that in the back of your head for when we move to the rest of this unit and we start talking about cancer. And we're going to talk about how weight loss, particularly unintended weight loss, and significant amounts, tend to be related to an oncological process. He sometimes has trouble remembering names of people we've known for years. So that could be the beginnings of perhaps some dementia, perhaps some Alzheimer's. We don't really know enough yet. Joints are terribly stiff when he awakens in the morning. That definitely sounds like arthritis, which he probably has if he's an older adult. But the big thing is he just seems to move so slowly. So that's the one that's associated with the Parkinson's disease. Remember, we talked about that bradykinesia. It's that very slow shuffling gait. And, you know, I was talking about my little lady at the personal care home before. Oh, God love her. We used to eat dinner at the personal care home at 4:30. And her family was well off. So she was in, she was not only in a private room, she was actually in the little suite. Like she, you know, she kind of had, you know, a couple little rooms there. She had a couch in there and everything. But Lord knows she was as far away from the dining room as she could possibly get. And I kid you not, we ate at 4:30. If she wasn't on the move by 3:15, she was not going to make it there on time. And especially, you know, until we got to the very end, like at the beginning, she absolutely refused to use a wheelchair. She could walk. She had a rolling walker, and she was going to walk herself to that dining room. There was nobody going to be pushing her. But if she didn't leave her room by 3:15, she was not going to make it on time. And she would walk and she would take rest. She would sit on the different chairs or benches along the way. But you want to talk about a slow shuffling gait with emphasis on the slow. It was quite interesting. All right, so the last thing I want to kind of focus on today and talk through is talking about management of these chronic neurological disorders. So, the other day we talked about stroke and we were talking about the acute piece, but now I want to kind of focus a little bit on the residual deficits. And then also think about MS, MG, PD. ALS we didn't really talk a whole lot about, but it's a progressive muscular disease. Typically, your life expectancy is going to be about 5 years. They get progressively paralyzed. They end up dying of aspiration or an aspiration pneumonia, respiratory failure. But all of those things are chronic neurological disorders. So, I want to look at the different body systems, and let's just talk a little bit about some interventions used to maximize function and preventing complications. This was kind of one of the exercises that was on the online class worksheet for class 1. And it was kind of focused around the stroke patient. But, since we didn't get to that the other day, I want to talk about it now and really kind of pull in the similarities with MS, myasthenia gravis, Parkinson's, and that sort of thing. So just kind of thinking about from a cardiovascular perspective. With these disorders, they're going to have a decrease in mobility. So with that decrease in mobility, we get concerned about things such as the development of blood clots. So all of the things that we talked about in Unit 5 and also Unit 3 after orthopedic surgery, using things such as TED hose, postoperatively SCDs, getting them up and moving. If they can't move out of bed, using the foot pumps, your ankle circles, flexing your calf muscle, really trying to promote that circulation. Range of motion exercises, repositioning the patient, all in an effort to really maximize blood flow. From a stroke perspective, cardiovascular, obviously they had some risk factors that led to that stroke. So thinking about how to control their blood pressure through medications, through diet, low sodium diet, controlling their fluids. It's a very fine balance. I want to make sure my patient is hydrated, but I also don't want to I don't want them to be overhydrated and push their blood pressure up as well. So you kind of have to balance that out. Certainly other diet modifications, low fat, low cholesterol, looking at minimizing those risks, particularly if we're talking about stroke. I really want to spend some time on respiratory, and this really ties back to the unit where we just were. What is the effect on the respiratory system for somebody who is not mobile? Okay, they have pooling of secretions, that's going to put them at risk for atelectasis. It's going to put them at risk for developing pneumonia and, just turning into a major problem. So all the stuff we talked about in the respiratory chapter, the turning and the repositioning to mobilize the secretions, the chest physiotherapy, the hydration to thin out those secretions, the huff coughing, actually encouraging them to cough and clear out their airway. Okay, incentive spirometer, positioning of the patient. From a respiratory standpoint, and it kind of goes into nutrition, these patients, if they have a problem swallowing post-stroke, myasthenia gravis, Parkinson's, as it progresses with the drooling and the swallowing, they're going to be at risk for aspiration pneumonia. Okay, so really taking care of their respiratory system is going to be a very important part of what we do. From a nutrition perspective, start with the swallowing. These are foundational concepts. When you have a patient who's on aspiration precautions, what does that mean? What do we do? Making sure they're sitting up all the way, making sure they're in a chair rather than the bed, that they're straight up. The small bites, the chin to the chest to help promote swallowing, the double swallow technique. So they swallow, then they swallow again before they take the next bite. Small sips of liquids, no straws, because it's hard to control that. If they're on aspiration precautions, having suction nearby. Those things are really important. If they're not able to take in PO nutrition, and now we're talking enteral feeding. Oh, wow, now we're really going back into fundamentals, aren't we? Thinking about positioning in relation to that. How do you administer an enteral feed if they have a PEG tube? You know, verifying placement, verifying residual, making sure they have enough free water, that they're not getting, you know, dehydrated because of the high concentration of the actual feeding solution. Okay, how do you know it's working? Assessing bowel sounds. So all those things that really come into play. And, you know, when you think about it, we talked about this in your late stage COPD patients, but how do we get enough nutrition in there to meet their needs? Your end stage COPD patient often expends more calories breathing and eating than they take in through eating. And that's why your late stage COPD patients look cachectic, they look anorexic. Okay, so when you think about somebody with the CVA who might have problems with swallowing, or myasthenia gravis that has problems with swallowing, or Parkinson's, they eat so slowly that they don't tend to take in enough. You know, and thinking about the effects of that. Parkinson's patients, all of these really very important to have, you know, small frequent meals, because they might not be able to take in a whole lot at one time. That's a big thing. GI elimination. Okay, again, if you go back to mobility and mobility, what's the effect on the GI tract? It's going to slow everything down. Well, how many of those medications did we talk about today that also had constipation as a side effect? So it's really important looking at those non-pharmacological things first, increasing fluids, increasing fiber, soluble fiber and insoluble fiber, and increasing their activity level. Yes, if they can get up and walk, that's the best thing ever. But even if they can't, if you have somebody who's chair-bound or bed-bound, repositioning, doing those exercises, that does help stimulate some peristalsis there. GU elimination. You know, again, sometimes this is being able, a mobility issue, getting to the bathroom, but it's also positioning. So if you go back to your basic concepts of GU elimination, if we're talking about a male, how do they void best? Stand them up. If you're talking about a female, how do they void best? Put them in a sitting position. So thinking about things like that, that's true for moving your bowels too, from a GI perspective. For your MS patients, it is not uncommon for us to have to do what we call the Credé maneuver. So they'll pee, kind of push a little bit on their bladder pelvic area, and they might empty out a little bit further. Okay, just to try to keep that, you know, that bladder emptied out, because if they're retaining urine in there, it might not be a large enough amount that it's considered acute retention that would be life-threatening. But if you have urinary retention, it's going to increase their risk for infection, and infection is a major trigger for an exacerbation of MS. So really critical things there. Integumentary. Big issue when you have decreased mobility, just increased risk for skin breakdown. They're going to be at higher risk for skin injury, just because if they have a nutritional issue, a hydration issue, you need those building blocks to keep skin intact, as well as heal skin that has become non-intact. So repositioning is important. Skin care is very important. Safety devices, making sure we're not having pressure on those bony prominences, or repeated trauma to certain areas. From a musculoskeletal standpoint, all of these, we want to maximize function for as long as possible and minimize complications. So getting them out of bed to the chair, ambulating, range of motion exercises to build up those muscles and to keep those joints functioning. Okay, tonight, seriously, when somebody who lives in your house goes to sleep, let them sleep for a little bit. And then I want you to go in there with a flashlight. Don't scare them though. I want you to go in with a flashlight and look at the position of their feet. Okay. Their toes are probably pointed out. Their feet are extended. That is a natural position that your body will go into. Okay. If your stroke patient or your Parkinson's patient or whoever stays like that for a long period of time and doesn't move, we move around in our sleep, not as big of an issue. But if they stay in that position and they can't move, that muscle will permanently shorten and they will develop foot drop. So not only does that become a functional issue because they can't walk as well, but it becomes a safety issue because they're more likely to fall when they do try to walk. So physical safety is going to be a big issue with these patients. certainly from a neurologic and a cognitive perspective, particularly with your stroke patients, but especially as well with the Parkinson's patients when you get to those later stages. You know, how does that affect their thought processes and in relation to their safety? How does that impact their family? You know, when they have that confusion or they have those outbursts, you know, how does that affect that family connection? Anytime your patient deals with a chronic illness like this, especially a stroke when something has changed, that puts a lot of stress on the family because roles change, responsibilities change, and that person is never really exactly the same as they were before. And that can be very devastating, you know, to the patient, but a lot of times to the family members. So that's something to kind of keep in mind. And that ties in with psychosocial as well. You know, both for the patient and the family, that how are they coping with this? What types of resources do we have to help support them? You know, as I mentioned in the last class, you know, about my dad when he had a stroke, very big change to our family. You know, how far back he's come is absolutely amazing. But one of the sources of his psychosocial strength, and I would say my mom's sanity too, is an adult day program that he would go to 3 days a week. Unfortunately now it's been kind of crazy since those programs are closed as well with this COVID-19. So now what was a break to that spouse caregiver or, you know, adult child caregiver, you know, is now definitely creating more stress. And you can see it with behavioral changes in the participants and residents, and you can certainly see it in the coping mechanisms of the caregivers as well. You know, we don't talk a whole lot about caregiver role strain, families, but also, you know, healthcare staff too. It definitely is a stressful thing to be able to manage that. So when you talk about these disorders, and really we're talking about it from a neurodisorder perspective, but really with any type of chronic disorder, doesn't matter what you're talking about, any type of chronic disorder, you know, our goal is always to keep the patient as functional as possible for as long as possible. You know, really supporting quality of life, supporting their coping, you know, supporting their ability to do those ADLs and supporting the family through that as well, because we have the patient, but we're also taking care of the family as well. All right, let me check out the chat box. Are these interventions for stars? So these interventions are kind of for everything neuro. When you talk about any type of neuro disorder, you know, if it's myasthenia gravis, what are we doing from a nutritional perspective to keep them safe? They definitely need aspiration precautions. Probably not as big of an issue with myasthenia gravis on GU elimination or even integumentary, but for some of the others it is. So the reason I did this and the reason I brought it this way was for you guys to really look at this the same way you looked at the respiratory stuff. Okay, yes, there were some differences between asthma and pneumonia and COPD, etc. And yes, there's some differences between the rehab phase of the stroke and MS and myasthenia gravis and Parkinson's, but there's a lot of similarities as well. When we talk about maximizing function and preventing complications in all of these body systems, these really apply across the board. And, you know, through this conversation, especially these last 10 minutes, really looking at these body systems, this all goes back to foundational content. There wasn't really a whole lot new there when you think about it. You know, the respiratory interventions, the nutritional interventions, you know, how do you maximize calorie intake in a patient who needs the nutritional support? What do you need to do for someone who requires aspiration precautions? What do you do for someone to promote that GI elimination? A lot of that was it wasn't new content. It's revisiting that foundational content and now thinking about it in relation to somebody with a chronic neuro disorder, okay? All right, well, why do they have problems with the GI elimination? Could be a mobility thing, but a lot of times it's also related to a side effect of a medication. But you're always incorporating those fundamental concepts. When you guys take NCLEX next year, And, you know, I say next year and it seems like so far away, but it's not. It's going to be here before you know it. But NCLEX, when they look at those questions and they break it down, they have different categories. And one of the categories is basic care and comfort. And I will tell you, having looked at statistics for years across the board and also at Penn College, when we look at students' performance on the NCLEX and on the ATI predictor, and you're asked questions in all these categories, that basic care and comfort tends to be one of the lower scoring areas. And it's not that you don't know it, because you certainly do. But sometimes as you progress on, you're always focused on, you know, what's the problem? What's the main disease process? What's the med? What's this? And kind of forget some of those foundational things. You know, when you talk about Parkinson's, okay, yes, you can know the pathophys, you know, you can know the medications, but if we're not going back to those foundational things to maximize their functioning in all of their body systems, we're missing a key piece of their plan of care. Okay, so that's why, you know, and I know I sound like a broken record. I keep talking about foundational concepts and bringing them forward. And, you know, as you get into med-surg 2 in the fall and you get into more disease processes, I want you to take that foundational knowledge forward and think about, okay, well, now we're talking about myocardial infarction, heart attacks, ACS. Okay, when your patient post-heart attack has activity restriction and they're building up that endurance, how is it affecting all of these body systems? Because the truth is that it does. It has some effect on them. And it's something you need to think about. So, all right, I'm going to stop sharing my screen. Let me go back to the chat box and make sure I have covered everything here. If anybody has any further questions, go ahead and throw them in the chat box. I'm just kind of, you know, scrolling down from the top just to make sure I hit everything. But, you know, of course, I want to address any last minute questions. I don't see any more last minute questions. So I'll just give it a minute here. Otherwise, you know, we've kind of wrapped up the neuro stuff. I do want to give a plug again to those online class worksheets. Please go through and do them. Do the interactive case studies, upload those to Plato. When you upload to Plato, I do review your worksheet. I do give you feedback, okay? You know, if you hit the main points on there, I'm gonna note that in my comments. But if you miss something critical, I'm gonna note that in my comments as well. So they're there to kind of help guide you through that. Now moving forward, the second half of Unit 6 all relates to basic oncology concepts. So Friday is a big day for this, okay? So what I would strongly advise is that obviously you got to go through and do your pre-class prep, but I would also on Plato look at the online class PowerPoint prior to that, because we're going to discuss a lot of concepts. All of this is going to be in preparation for next Monday for a video case study. And this video case study was a woman who came and spoke to the LPN students several years ago now about her diagnosis with breast cancer, takes us through, you know, the whole symptom onset, the diagnostic process, the workup process, the chemotherapy, the surgery, the radiation, everything. And it really is a good case that really ties everything together. But we have to lay the groundwork for that video case, okay? So even though the video case is available, you know, once you upload the class 4 prep, you need to be prepped for that to really get the most out of that case. So Friday is a really, really big day. So that is all I have for today. I don't see any other additional questions, so I will sign off. Enjoy the rest of your Monday and have a great rest of the week too. I'll see you Friday.